Yes, so we have joining us is Dr. Kamini Doobay. She's the founder and organizer of the NYC Coll- Coalition to Dismantle Racism in the Health System. Dr. Kamani Doobay is an emergency medical medicine physician with an expert in advocacy, policy, and anti-racism curriculum development, institutional health equity strategy planning, and collaboration building as the founder and organizer of the New York City Coalition to dismantle racism in the health system. An intersectoral cross-functional collaboration among the medical community, community-based organization, the public health community, and the legal sector in New York City to address racism in our health system. So I will now invite Dr. Dubé to the virtual podium.
All right, thank you so much for having me. I apologize once again for being late, but I do want to touch upon some important topics that I hopefully think will be important in terms of moving forward together, tackling this important issue in Guyana. So just to provide some context, I grew up in Richmond Hill, so Little Guyana in New York. So this area is highly underserved. And it's diverse, it's a community of color. It's largely Indo-Caribbean. And when my parents are from Guyana. When I was growing up in this community, it was clear that trauma was very, very common. So what I mean by that, it was commonplace that basements were raided, people were constantly fearful of deportation, police cars would be parked outside of elementary and junior high schools, ready to arrest young people at the time. And despite sounding our voices, the external community was not very involved when it comes to community upliftment. And the community itself was often a wasteland waiting to be saved, or treated as a wasteland waiting to be saved. So when I say trauma was too common, when I was growing up, I saw my neighbor being chased by her husband. In his hand was a machete. I was standing so close that blood splattered upon my arm. My instinct was to jump in front of her. I saw too many women, including my own loved ones, roam the street at night to escape from unhinged partners. My own grandma, who I think is one of the most revolutionary people that ever existed, sacrificed everything for her family, and she ended up spiraling into depression and losing her own life because of isolation and depression. And the core of everything that I hope to do is love. I truly believe that love is the core of activism. But what we see is that many of our communities oftentimes are treated as these wastelands, and we have these outsiders coming in to help, but not necessarily knowing how, and not treating these communities as places full of vibrancy and cultural potential. So in the community, when I was growing up, people often waited until they were on their deathbeds before they would visit the hospital. And here you see an emergency department, and this is often where people went to receive care, waited until there was an absolute breaking point of trauma, whether it was suicide, whether it was a heart attack, whether it was a stroke. There wasn't preventive care, but there was emergency care where people showed up, oftentimes when it was way too late. So I found myself at the center of all of this, and then also at the center of the diaspora, knowing what was going on in our homeland when it comes to climbing suicide rates and the structural nodes that intersect to create the society that is often unfair and limited in terms of what we can do in Guyana as well. So I saw myself first as a community organizer, and then I began doing work in many communities of color around New York. So I began working in East Harlem on pediatric mental health. And I saw the same things where I saw many large organizations, whether it be government or academic institutions, entering these communities, providing quote unquote solutions without ever asking the community themselves, the members, what they needed and what can truly be used to help the community. So I found myself once again at the center trying to connect nodes between community-based organizations, faith-based organizations, and people in general to come up with solutions. And this is one of my favorite, I live in East Harlem, and this is very close. This is a community of color. And here you see a mural painted on one of the building walls. And it shows that this is not some underserved community alone. You see folks here, it's full of cultural potential, full of vibrancy, full of potential solutions. So we have to recognize that those closest to the problem are closest to the solution. So while many times we expect solutions from academic institutions and government, the community themselves are often full of the solutions. So let's go into the crux of what we want to talk about today. So racism. So this is the public health definition that I use when I do my work with many other activists across the country and beyond. So racism is a system of structuring opportunity and assigning value based on how one looks, the social interpretation of how one looks. So this is not, nowhere do you see biology or genes. This is purely based on how someone looks. And a lot of times in public health, we think about the disadvantaged, the vulnerable, and then we think about baseline. But whenever one group of people are disadvantaged, another must be advantaged. So what do we mean by that? We mean that whenever a community or a person is suffering because of oppression, we have to ask ourselves, who is benefiting from that oppression? So there are different levels of racism. So institutionalized is what we use to describe the link between racism and socioeconomic status. So here is what explains the differential access to goods, services, and opportunities. So why some people live in poor housing and don't have the same access to healthcare and employment and a clean environment. So this explains the association between status and race. And then there's personally mediated racism. So this is what we commonly think about in terms of assumptions about abilities, motives, and intentions. So because somebody is Black, because they look a certain way, because the color of their skin may be different, they are inherently different and they are judged differently. And then we have internalized racism. So what we mean here in terms of the public health definition is acceptance by members of the stigmatized race, but of negative messages about their own worth. So a sense of devaluation and resignation, helplessness, hopelessness. So why even try? I can't do it anywhere. Look at the place that I come from. Look at my community. People aren't doctors. People aren't public health officials. So why should I try? So these are the various levels of racism. So now let's think about this in the clinical setting. So a person comes into the clinic or the emergency department now. Because of the way they look, the color of their skin, the way they're talking, maybe because they're in a wheelchair or walking a certain way, automatically in the provider, the physician, there are biases. So for instance, somebody comes in, and this happens all the time in America, because they're Black, the provider thinks, you know what? They're not here because they're truly in pain. They're here because they are seeking drugs. They want pain medications. So now this influences the way a medical history is taken and the way a physical exam is performed. So instead of asking questions about their comorbidities, what they've been using for pain, their family history, instead of all of that, now questions are asked to figure out, is that person manipulating me? Are they playing me? So then this goes on to affect how you treat them in the clinic. Whether you underprescribe medications, overprescribe, whether you make a referral to the necessary clinics, whether you make sure that that person has good, adequate follow-up care. And that then perpetuates inequities within our system. It perpetuates the racial injustice that we often see in America and beyond. So because of that, I started this coalition, and our aim is to dismantle anti-Black racism within the system. But there are lessons that we can learn throughout the world, and notably in Guyana as well. So first of all, I want us to move away from very flawed explanations of inequity. So first of all, we know that first inequity or injustice was used or genetics was used. So Black people were thought to be genetically inferior to white people, and then people of color the same way. We moved away from that because that was an explanation to justify slavery. Then we moved to this lifestyle choices hypothesis, that people are trying to milk the system. They want welfare, they want social services. But do people want to live in poor housing? Do they want higher rates of incarceration, of asthma? Do they want higher rates of all of these medical problems? Clearly the answer is no. So we must move to the most accurate definition or accurate explanation, which is racism itself. So let's go through these principles that influence how we provide care. So race was constructed as a hierarchical system that privileges its creators. So here we know that oftentimes you have under-resourced clinics, hospital systems in communities of color. So here there's blatant segregation in New York, and I'll talk about that. But this happens in global communities around the world, where we know that there's a lack of resources because there's a lack of investment. Whiteness is normalized at the top of the hierarchy in the United States and then beyond. Most leadership looks like this. So this is just one academic institution I chose, New York University in America. Now I work for Columbia, but this can be any medical system. Leadership is largely white, even if the population is Black or brown. People, oftentimes the hospitals here, I often say they're made for English speaking patients. Nobody cares what language they speak. And then there's this link between capitalism and racism. And this is very, very, very important to figure out here, or to point out. So in America and in other imperialist nations around the world, we know that there was institutionalized slavery, right? So, and then even after slavery ended, white slave owners were given insurance for lost cargo being people, human beings who were treated as property. Now, how do you move from a society where first people were being treated as property, and now we have to treat people with humanity, dignity, and move towards a truly equitable society? How do you move from a society where whiteness was always at the top and Black people and people of color were at the bottom, and now there is this emphasis on profitability, on money, on profit-based medicine, and not a type of medicine where health is treated as a human right? So in many parts of our country, where I practice in the United States, in New York City, your zip code where you live has more of an impact on your health outcome than your genetic code. So even blocks apart, between communities of color and largely white communities, you have 10-year difference life expectancy. And we know that New York City, where I practice, is one of the most residentially segregated cities in the country. So more than 80% of Black people or white people would have to move to different census tracts for the societies to be equal or equilibrated. Now, let's talk, I'll tell you why this is important to Guyana. I just want to tell you here that in America, Black and brown people are largely or disproportionately the group that doesn't have insurance at all, or that has public insurance. So Medicaid is public insurance, right? As opposed to private insurance. And so in New York City, there's a system of very blatantly segregated care where people of color are served disproportionately at public hospitals. not the big academic specialty centers where it's much more resourced and there are more opportunities available for specialty care, mental health resources, all of this. So white people are seen 6 times more at academic specialty centers, whereas Black people are seen 3 times fewer at those types of places. And uninsured people, people with no insurance at all, are treated primarily at public hospitals that are overburdened. And even if you account for insurance or illness severity or other co-founders, still you have Black folks and people of color in general less likely, substantially so, to be seen at academic specialty centers. So these hospitals that are highly resourced. So now a lot of people say it's not the physicians, it's not the healthcare providers, it's the system that's corrupt. But we know that physicians are less likely to accept public insurance in areas where the poor are non-white and in areas that are residentially segregated. So this is blatant bias. And this is a system that is set up this way to benefit or to continue perpetuate white supremacy, whiteness at the top. So racism is a public health emergency. This man who is Black is brutally taken down and lost his life, killed by police officers after being wrongfully accused of having drugs on him. This guy is a white man who had just shot more than 20 people. And you can see how commonly he is arrested and it will be taken to the police station. So why is this the case? We cannot abandon this history of scientific racism. Scientific racism is something that was so prevalent and continues to be prevalent in the mindsets of human beings, right? Where these were real ads by physicians putting out ads in America and beyond for Black people to be used in scientific experiments. And at the same time, in media and legalistically, these caricatures, people were being stereotyped, particularly Black men, as lazy buffoons, as hypersexual, and the result was dehumanization. And the same thing happened for Black women, where Sartre Bartman was smuggled from South Africa to London. Her body was put on display. Even after she died, Georges Cuvier dissected her body and put it on display to provide scientific evidence for this quote unquote Negro race to hypersexualize Black women. There's a long history of anti-Black racism in medicine. You can see some of these years. Unfortunately, I don't have time to go into all the details of what these experiments were, some of them on children, right? To provide, quote unquote, a hypothesis for the inferiority of Black people compared to whites and people of color. And this still influences how we practice medicine. So just in 2016, there was a study that surveyed 222 white medical students. And more than half of the sample believed at least one false belief between the genetic, inferiority of Black people. For instance, that their clotting cascades were different, that they felt a different level of pain, that their heat tolerance was different, all these bogus things. And that same group of people would go on to undertreat Black patients with pain in simulation scenarios. This happens in our emergency departments where kids are undertreated for pain. And then even when Black people are brutally murdered by police officers, they're demonized. So unfortunately, I don't have too much time, but we know that slavery was institutionalized in Guyana, right? And then even after slavery ended, then indentured servants, Indian indentured servants were brought from India to provide cheap labor on plantations in Guyana. And this was part of the Gladstone experiment, where of course a white imperialist brought these folks over, promising them lots of things. as they tended to do, only to see how blatantly unfair the system was, not just for Indo-Caribbeans, but for Black Caribbeans as well. So you have these derogatory slangs, not different from America, not different from the caricatures that I just showed you. So coolies, slaves, paupers, even up to just a couple years ago, this is an ad that stereotypes coolies in an Australian newspaper. And what the British imperialists did was what they did in many other nations, right? So this is from one of Elizabeth Jaikaran's writings. Basically, the British imperialists told the Black folks in Guyana, don't speak to the Indians, they are your enemies, they're vile and carry diseases. And then told the Black folks in Guyana the same thing. Don't speak to Indians, don't speak to Africans, right? They pitted these groups against each other and used these stereotypes to perpetuate the oppression. So in America, in New York City, this is one of the areas that we're working on. And I'm so sorry that we won't have the time to really dig deep into this. Maybe we can set up another time. But in the streets, if someone is experiencing a mental health crisis, oftentimes they're termed an emotionally disturbed person, which we have worked many, many years to get rid of this term, which is stigmatizing. It is not uncommon to see a human being being carried in one of these body bags in the streets of New York to a hospital, right? Because this is what happens when police officers who are not given adequate training are then being told that they must address issues of public health in the street, whether it's domestic violence, homophobia, and other mental health crises in the street, drug possession, substance use disorders. These are not things that police officers know how to deal with, but yet they are the ones that are sent to the street when these crises occur. So we saw this rise in emotionally distressed calls in New York City. And then the city set up co-response teams. So this included a mental health professional and an officer, which is being underutilized. Unfortunately, I don't have time to go into all this, but Guyana and New York are not very different in the sense that mental health is stigmatized and there's an inadequate response. And we have failed as public health professionals in terms of providing a true response. Now, if you look at the data in Guyana, this is a paper that was published on, once again, police officers who are providing sort of the response in the street. And here you will see, based on the data, that largely slow people that have contact with police and persons with mental health crises in the street are usually not doing anything wrong in terms of big crimes or violent acts, but yet they have all this interaction with police. This takes up a lot of police resources, but then also these people are not getting the help that they deserve and they need. So how can we actually fix this? So number one is actually providing structural racism and violence intervention training for police officers. This is something our coalition is doing. We're working with the NYPD or police in New York, and we have possible ways to do this in other parts of the world. So what does a co-response team look like? So this can be a mental health professional or a civilian. So faith-based leaders, community-based leaders in Guyana itself, and then to provide community hubs. So we often think that a hospital is the only place that you can receive care. We know that that's not true, right? When people are suffering, they often go to their churches, they go to their mandirs, they go to their mosques, they go to their senior center, they go to another person's home, right? And then we have the violence interrupters, where it's not a doctor, it's somebody from the community that can provide interruption. And this, I wanted to show a short video of how this model can work, but unfortunately, I think we're actually lacking in time. But here, what this model shows is that violence is not something that should be stigmatized on the street. When kids are growing up and they're exposed to violence, and then they end up committing acts of violence. This is not something that should just be stigmatized, because violence itself is a public health crisis. So there must be public health solutions to this, right? So what does that mean? Providing solutions that are based in the community, those closest to the solutions, or sorry, the problems are closest to the solution. Once again, I am very, very sorry that I messed up the timing here. And I got my hour. I swear to God, I wanted this to be a very interactive presentation, and there was a lot more here going on. But maybe we can work with you all in really scheduling another time outside of the conference to speak further on what this could look like in Guyana. Thank you so much for having me.
All right, so thank you very much for that, Dr. Doobay. I think we still have some time. We can play the video.
Okay.
So we'll go ahead and play the video, and then we don't have any audience here, but I don't know if anyone is in the chat. Oh, and we have George here who might want to ask a question, and I see someone else in the chat on the live session. So if you have any questions, feel free to add it to
yeah, you know what, I can actually also just send out the video and to have it on the website, but I'd rather take questions and use the time like that, if that's okay.
So I think we have a question from our audience.
First, I want to thank you. I mean, you're spot on. I am Hispanic American, live in New Jersey, but grew up in the area of New York, and I've been coming here to Guyana. And you're absolutely right. New York City, apart from population density, is very similar to Guyana, and a lot of the issues that are here are also in New York. So you alluded to the fact that the work you're doing with training the police officers can be done elsewhere. What would you need here in Guyana to carry out that similar training with police officers?
So that's a great question. And this is something that, this is a model that we're still working on in New York and other places, other cities across the country and then globally. Really, it's just the commitment. In terms of resources, we have resources, right? And it's unfortunate that so many folks in the diaspora in New York and elsewhere, once you leave Guyana, you're like, okay, I'm done. But I promise you that these are resources that we have. All we need is the time in terms of being able to set up time with the police force to have these workshops, because education here is key. We see how scientific racism is needed in terms of awareness of what that is in order to truly have this cure violence and other violence interruption methods that can work. So we need commitment from the government that there can be time allocated in terms of the police officers scheduling and things like that. But this is something I'm committed to. This is something that can work. It's not like we need a ton of resources for these initial workshops to be carried out.
All right, so thank you for that. And so one of the things that I've noted is that in Guyana, we still have the 1930 ordinance. We don't have a mental health legislation. And hopefully by 2022, that bill is going to go to Parliament and we're going to be able to see some changes in that area. But I remembered working with the police to get someone off the street, and the police told me straight up, I can't do that. My job does not require me to do that, and they refuse to provide aid in getting that person to care, right? So I think you putting that out there, that you're willing to provide the resources, and just you want commitment from the police and commitment from the government of Guyana in getting this done. I think this can help us move forward. Is there any questions in the chat? Or
yeah, and I think it's important too, because even here, right, the police officers are expected to address these mental health crises in the street, but they don't have the tools, right? So a lot of times we're quick to blame the police officers, right? Because now that police officer is also a human being. And, once you're taunted by someone or you're threatened by someone who's experiencing a crisis, your instinct is to react. in the hospital, we have many tools. We have, if someone actually needs pharmaceutical intervention, we have sedation. We can sedate someone, who we can give them medications who can help them through a crisis. We can speak to them calmly. We can put them in, in a room and provide psychiatric tools and help and things like that. A police officer doesn't have that in the streets. And then that same Guyana study that I showed you, many police officers actually said that family members were hands off and wouldn't actually intervene when a situation was going on. And we can't necessarily expect them to, but we need more trained individuals to help the police officers as well, whether they're trained civilians, community interrupters, whatever you want to call them. They're called different things in different places. But I agree with you 100%.
So I have another question. So here in Guyana, there is a suicide hotline, but my understanding is that the staff that handles the calls are actually, although they're counselors from the police department. And so I find it interesting that they have counselors, staffing the phones, yet there's no training for the police officers to handle the crisis out in the streets. It almost seems like two different worlds. And here suicide is still illegal, and the Minister of Health is working on changing that. And there's going to be legislation soon that there is a mental health plan that's going to be coming out, as Ms. Solomon alluded to before. There is also the decriminalization of suicide here, which it must happen, and it will shortly. But do you think, what do you think about that it's actually the police department, although be it wonderful counselors that want to do good, police department staffing a suicide hotline?
I think that's such a fabulous point you just brought up. That's so important to emphasize, to point out. And this is happening really all across the world, where police officers are tasked to handle these hotlines as well. Why is it that if somebody is experiencing, a physical crisis, right? If I realize my blood sugar is extremely low, or I'm having chest pain, my thought is not to call a police officer ever, right? My thought is to call a physician, to call, the ambulance, the people that can truly help me. But this shows that how around the world, mental health, suicidality, depression, isolation, all of these things are not treated as health or public health crises. They're treated as criminal acts. And I agree with you, it must start with the decriminalization of suicide, decriminalization of homophobia, of mental health crises. Because if you do not acknowledge it for what it is, you cannot treat it like a public health crisis. There is no way ever a police officer should be the one. If I'm experiencing isolation and depression, bullying as a teenager, I should call some anonymous hotline and get a police officer. There are too many places, especially places that are, the population is largely Black and brown, that a police officer is not somebody that's equated with safety, but the person is equated with a threat. And if I recognize that I'm speaking to a police officer, I'm going to put down the phone. I'm not going to want to tell that person my problem. That's going to perpetuate these suicide rates and increase them. So I agree with you. We have to change the way we're thinking about mental health and thinking about the structures that can actually help people. There is no way that a police officer should be on the other side of that phone.
I really enjoyed that response. It was really good. And I think it is good that it's coming from somebody who is outside of Guyana. You might be Guyanese, but it is coming from someone else who understands why we need to really move to really decriminalize suicide and really decriminalize mental health, because technically still it is a law in Guyana that decriminalize mental health. And so there is one question in the chat, and it is by Mr. Stanley Buddy. He's asking, is there a link between mental health and racism?
Yeah, too much of a link. Stanley, I wish you caught some of the slides that I showed earlier, but I'm also going to leave my email and number in the chat because this answer is loaded. The link between racism and mental health is so profound, from the criminalization of it. Think about the United States and how all these Black men, their lobectomies were done on their brains to prove that they had a higher rate to aggression, in terms of aggression, in terms of quote unquote bad behavior, to prove this link between inferiority of Black people and mental health crises, and how this scientific racism was then perpetuated and then providing solutions in terms of mental health solutions in communities of color. There's so much data in terms of moving forward, and then all of this history that too many doctors choose to ignore. People think they can treat the patient in front of them, but disregard this history. So Stanley, I would like to speak to you separately because I can share all of the, the slides and the information. I feel so bad that I showed up late because of the time difference, but I'll drop my email here as well. Thank you so much, Devrindra. I will take note of your email as well.
And just to point out that your full lecture will be on our website and our Facebook page. We are building a library of all our wonderful speakers sessions from the conference. And we do have plans for many more gatherings that, obviously we want you to be part of. I just wanted to bring up another point related to legality and its vocabulary, right? There's a big push by folks from the American Suicide, the AFSP, the American Foundation for Suicide Prevention, in changing our vocabulary. The term committed suicide implies that you're committing a crime. And the new push is to say died by suicide, right? Or death by suicide. Because until we start changing our own vocabulary, we're still going to be restricted to our minds to think in a different way, much like how you showed about racism as a deep root in our culture. Our vocabulary, it also shows this deep root.
Yeah, I very much agree. Language matters. This is the whole campaign that our coalition is focusing on in terms of speaking about folks with mental illness and actually physical, other physical problems in the clinics, in our emergency departments and beyond. We are even in terms of how you code mental illness and you bill for it in America, something called ICD-9 codes. A lot of times we criminalize mental illness and other forms of medical problems.
So thank you for that, Dr. Doobay. Do we have any other questions or thoughts you want to share? Okay, you can unmute your mic and go ahead, Dr. Sharma.
Yeah, thank you. I'm also sorry I got this late, but this is really wonderful. This is exactly what I've been talking about. For one thing, I believe that nomenclature has got to change, and we got to get the DSM-5 change in terms of a lot of those terms. They're very old. They don't make any sense. When I ask medical students, what do you understand by the term schizophrenia? They can't explain it because it's very confusing. These are very old terms and they're really not good. You can't be talking about splitting of the mind of something that's neurobiological in somebody's brain, that's genetic. It's bizarre. And even the word mental, I just think it carries a negative connotation in its own self. Mental, where does it come from? Mind again. You ask somebody what's the mind, you get about 10, 20, 30 different definitions. So we got to talk about a person's brain is really brain health. And I even think that WHO has to change this thing from mental health and physical health. Mental health is exactly physical health. It's in the brain where it's nothing abstract. It's all about people's brain not working well. And we now know, we see the PET scans showing exactly the brain areas that are bad. Why are we confusing people? We got to make them understand you're dealing with the person's brain. Let's treat it as a brain problem. I think if we change those terms, Doc, I like how you mentioned the terms. You got to make that movement happen. We're stuck in the old ways and the old time, and we're asking people to see us in a positive light, what we're representing ourselves in a very negative light. So something I'll be talking a lot about.
100%. Yes, Dr. Sharma, I think it comes from us. And we tend to label our patients all the time. And the way we educate medical students, it's very much the same. And we know from large scale data that Black and brown people are diagnosed with higher rates of bipolar disorder, schizophrenia, narcissistic disorder, antisocial disorder, and we tend to label people quickly. A lot of these diagnoses, if you're going to make it, it must span over 6 months. But we don't wait for that time. We don't wait for that.
Yeah, that's what he was talking about, that racism thing. It was way back in England, just the way somebody talk, and then they just interpret it as aggression, and they just view somebody's color and see them as a potential threat, and it's horrible, and they cannot use that anymore. It's got to stop. But doctor, even there was I think at one point there was a charter that they should destigmatize the word psychiatry, and the psychiatrists were even falling into the prey of stigma, because psychiatrists also get a bad image by the fact that they're dealing with people with psychoses, and this psychosis is just a very small percentage, a small fraction of all psychiatric problems. And the people with the majority of emotional problems don't come out because they don't want to be associated or seen by a psychiatrist. So it's truly unfortunate. Terminology is we got to look at that.
Definitely.
Thanks. And thanks for very good. You're really on top of this.
Thank you. And hopefully we can do some more collaboration in the future.
Yeah.
Beyond this. Yeah.
Yes. Absolutely. And we can be a gateway to that. Because again, we're both at Columbia and we're here in Guyana. So we have a 75-year plan, as Dr. Christine Hoven says. So we'll be here for a long, long time to come. And we do have a lot of plans for a lot of more workshops and sessions and future conferences. Obviously, this is the first year of our conference. We're going to have an annual conference here, and we've already spoken with the Minister of Health. There's a couple of more conferences that are coming up early next year and in the middle of the year that will absolutely continue this conversation. Thank you so much, everyone, for such a great conference. Our last session is in room 1. So